السلام عليكم ورحمة الله وبركاته. أساتذتي وزملائي الأعزاء، طبعا كل سنة وحضراتكم طيبين وبألف خير. We're sorry for this technical problems that happened, and today we have a very special day actually after Eid holiday. كل سنة وحضراتكم طيبين. Today we have with us two eminent figures of nephrology, Professor Yasser Abdelhamid, Professor of Nephrology, Asr Al-Aini, and Dr. Ramy Aboubakr Al-Shahat. He's consultant at Oman, البلاد العرب الشقيقة. بنرحب بيه معانا. He's senior consultant of nephrology. Today we are going to talk about, we'll start by Dr. Yasser or Dr. Ramy. Dr. Yasser?
Yes.
Dr. Yasser will talk about a very special topic actually, with dilemma of biomarkers in EKI, biomarkers of EKI, how to apply, and what's specific and what's non-specific, and if there is diagnostic significance, and moreover, if they have prognostic significant or not. I think we're going to have today very special night from Dr. Yasser. اتفضل Dr. Yasser.
Thank you, Professor Kamal, for your kind introduction. And our aim today in this session of Egyptian Society of Nephrology and Transplantation CME meetings is to talk about diagnostic markers. And this is the first part of my talk that can be about biomarkers of acute kidney injury, trying to reach somewhat clinical application of this biomarker. First, this is my agenda. What are diagnostic markers of acute kidney injury biomarkers? How to identify the targets? How to identify the targets of biomarkers? Which one to do biomarkers for? Combining biomarkers, is it we are need one or single biomarker or multiple biomarkers? Action plan according to these biomarkers and somewhat about the future. Let me start by AKI biomarkers. These are biomarker type including stress biomarkers that are targeting or detecting cell stress, damage biomarkers that indicate kidney damage, already kidney damage, structural damage in the kidney markers, and functional biomarkers. We can classify biomarkers according to these. Stress biomarkers early before the injury, damage already occurred, and functional biomarker detecting a change in function. These are the way from stress to further damage. You can see that no kidney injury, subclinical kidney injury, there are stress biomarkers. Why? As already kidney function started to decline, here is the place of functional biomarkers. As we progress, furthermore, there is damage to the kidney and more kidney fibrosis, and this starts the place of finding of damage biomarkers. So stress early before change on the function, functional biomarkers, and they start to appear the damage biomarkers. These are the biomarkers we know according to classification, as I mentioned. The pre-injury phase, which is the early biomarkers to appear, or the best one found to appear early, are tissue inhibitors of metalloproteinase and type 2 and insulin growth factor binding protein 7. These are pre-injury or stress biomarkers, the most important of stress biomarkers. While detecting the function, as we all know, is cystatin C and creatinine. These are the functional biomarker all. No, while damage biomarkers, I think will be the most other biomarkers all know, KIM1, INGAL, interleukin 18, LFAP, and etc. Of all other biomarkers, all are damage biomarkers. Comes another important question about the site of origin, from which these biomarkers occur. Of course, functional biomarkers from the glomerulus, detecting glomerular filtration, which is the function. Most are tubular biomarkers, while in the proximal tubules, there are markers of cell arrest, such as tissue inhibitors of metalloproteinase, insulin growth factor binding protein 7, while in distal tubules, markers of injury, including INGA. These are the sites of origin. Someone can say that we can combine biomarkers. We can combine one glomerular and one detecting tubular biomarker. This may be a method of use, but these are tubular type biomarkers and glomerular type biomarkers. What are the best performing? This is the most important question, I think, in all of our minds. Kidney injury to the nephron, cell cycle arrest. It was found that it is not, especially in septic induced acute kidney injury, it is not that apoptosis. It was not found to be necrosis, or apoptosis was found to be cell cycle arrest. So the markers of cell cycle arrest became of importance. This cell cycle arrest occurs in G1 phase. These are tissue inhibitors of metalloproteinase 2 and insulin growth factor binding protein 7. So please remember these biomarkers that I will use later in my talk. Clinical use of these biomarkers can be diagnosis of early stage AKI, which we all search about, identification of subtypes. Are we in pre-renal, renal, or something like this? Or, of course, the etiology. Progression, what about the prognosis? Nephrotoxicity and long-term outcome, immediate prognosis and long-term outcome. These are the limitations of the use of clinical biomarkers. And I think for these factors, we all still now not using biomarkers regularly. It cannot differentiate pre-renal from renal acute kidney injury. There is a wide range of patient variation, and you can all know that patient acute kidney injury is not a static patient. It is a wide range within the patient themselves and all in between patients. Increased costs, of course, and need for multiple assessment, not single assessment of a biomarker, and lack of outcome improvement by the use of this biomarker is still present till now. No, most of the studies did not show any outcome improvement with the use of these biomarkers. Which one to use the biomarkers? I don't think that we can use biomarkers for all patients. Which one to use the biomarkers? We are to select our patients for detecting biomarkers. These are the risk scores detecting which patient admitted to ICU are at risk of acute kidney injury. One of them is the renal angina index. One of them is the Malhotra score, which is used especially in ICU, and AKI 1, 2, 3 according to stages, or only in stage 2, 3 scores AKI, which are used within 7 days of admission to ICU. This is the renal angina index. The term renal angina resembles the cardiac angina. In cardiac angina, we use markers. In cardiac angina, we use markers to detect the condition and to treat the condition. And here is the renal angina, similar that it is an injury that we need a marker for. Injury that we need a marker for. This renal angina index depends on risk strata. You can see them: ICU admission, solid organ transplant, mechanical ventilation, or serum creatinine to baseline, injury strata, presence of decreased or no change, and 1.5, 1.5 to 2, double serum creatinine. Multiplying the score of risk by the score of injury yields a score of 1 to 40. More than 8, renal angina index indicates that the patient fulfilled these criteria. He is at risk of acute kidney injury. Another score is Malhotra score, developed in Cleveland Clinic for patient admitted to ICU. Number of factors: CKD, chronic liver disease, etc. As you can see, congestive heart failure, hypertension, each has a score of 2. Here, pH less than 7.3, score of 3. Calculation of this score cutoff of more than 5, positive predictive value of risk of acute kidney injury and of 32, and a negative predictive value of 95%. We identified the patient at risk using the scores, either acute kidney injury score, risk score, renal angina score, or Malhotra score, or any other scores of these developing scores. What are the action plans to take? What are the possible action plan to take according to this? Can we identify only the patient at risk, or according to this, we are to jump to an action plan? This action plan can be presented by a care bundle a care bundle, application of a care bundle inside the ICU, nephrology rapid response team, and electronic alert. These biomarkers needs, of course, validation in multiple studies that they can do the job appropriately. In this study, in 2020, was found that validated biomarkers can predict the development or progression of AKI and may provide opportunities for intervention initiative of a preventive strategy. So, biomarker followed by initiation of preventive strategy. And KDIGO, implementation of care bundle according to for patient at risk, care bundle for patient at risk, and these are the components of care bundle. If you look to the components of these components, you can find that it constitutes most of our actions taken to regularly to patients admitted to ICU: maintenance of volume status, mean arterial blood pressure 65, normoglycemia, serum creatinine renal output monitoring, hemodynamic monitoring, discontinuation of nephrotoxic drugs, of course, as is an ARBs. Also, this carries the important dilemma, alternative to radio contrast agents. This is the care bundle, in addition to care of a specific nephrology team, of course, not that simply ICU team. In this study, AKI, prevention of AKI, TAI in P2 I mentioned, by multiplication result by insulin growth factor binding 7 of the KDIGO guidelines compared with the standard care significantly was found to reduce the AKI incidence in cardiac surgery patient, risk reduction 16.6, which is a good number in 2017. This was our study in Asr Al-Aini regarding these care bundles. We classified patients 98 to intervention arm application of care bundle and 108 are allocated to observational arm without a care bundle. Classification of patient or allocation of patient to intervention or observational group, but according to Malhotra score, I have a specific mentioned. This is the no difference between the scores, market differences, or no much statistical difference, was not much different. And this is what we found. In observational arm, higher incidence of AKI at 48 hours, while at intervention arm, lower incidence, which was significant change. Regarding 30 days mortality, although was found not significant, interventional group was found to have lower mortality than the observational group. Another one is the nephrology rapid response progress, who to have this rapid response team, designed to specific nephrology event and acting to patient at risk. Please remember that we are speaking now about patient at risk for acute kidney injury. This patient high risk scores, positive biomarkers indicated for activation of this nephrology rapid response team. Moderate risk and a follow-up, etc. So we define first the risk according to patient selection, then the biomarkers. If was high risk with high biomarkers, this indicates we are to take an important action. What about the electronic alert? These electronic alerts are pop-up alerts that appear immediately in the patient file when you open this electronic patient file according to the risk scores mentioned above. This is one of the actions that, according to risk scores, no need for biomarkers, pop-up, this patient is directed to or subjected to acute kidney injury, please take your appropriate actions. Studies of these electronic health record alerts that are published in research journal found that 6,000 patients, good number of patients, is count 30 electronic health pop-up record for AKI with an associated set upon provider opening of the patient medical record. أول ما نفتح الفايل نلاقي الريكوردز دي اتفتحت عندنا ان البيشنت ده at risk of acute kidney injury, primary outcome progression of acute kidney injury, dialysis, this within 14 days. They found that, unfortunately, as usual, did not reduce the risk of primary outcome among patients with hospital outcome. So we have a lack of the use of this. Now, results does not help us in spite of this progression in advance in introduction of these methods. advanced artificial intelligence techniques, implementing care bundles, combining with improved outcome in patients with acute kidney injury. So combine those two actions, alerts and kidney alert. What about combining biomarkers? This study failed to demonstrate, unfortunately, we all search for this, troponin-like diagnostic performance of a single use of AKI prediction biomarker. We are searching for this. Failure to found this. We cannot rely upon a single biomarker. This is a good example of combining biomarker, combining TIMP1, insulin growth factor, 7 in the nephrocheck in urine. Nephrocheck in urine Diagnostic, approved 2014 by FDA. This is the result. It is calculated according to risk score by this equation. And a 0.3 cutoff value found to have high sensitivity while preserving acceptable specificity. يعني ممكن بالدبستيك نفروتشيك دي دبستيك to detect the markers in the urine وهي بيحسب الكالكوليشن المعادله ان هو found this patient الريسك بتاعه 0.3 or higher or lower than 0.3 cutoff found to have high or low risk. This study increased multiplication factor admission associated with AKI in first hour, probably due to short half-life of this marker. Very early detection of acute kidney injury. In cardiac surgery, intraoperative rise of these markers found to be related to later development of acute kidney. So we did not find a single marker. We found a multiplication or combination of markers. Also, we identify patient jumping to chronic kidney disease. Unfortunately, the limitations, not for ambulatory for low risk patients, should be used for high risk patients. لسه الاستعمال في البوشنت low risk مش that common. Limited data below 18 years old, not in severe established, of course, early in stage 1. Not valid in nephrotic range proteinuria. Proteinuria gives false results, considerable overlap between different rifle criteria, cannot identify which stages exactly we are in regarding acute kidney injury. False positive in low-risk patients and in cases of urine dilution, which is occasionally met in cases of ICU patient due to use of IV fluids. This is another study done in Australia by me and our team about interleukin 18 and resistivity index in early detection of acute kidney injury. And you can see that KIM1 was the best specificity, nearly 100% of detection in sepsis-induced acute kidney injury, followed by resistivity index, and the later was interleukin 18. Coming to future look, microRNA, now widely used in many of the studies, it enters in many entities of pathology such as apoptosis and inflammation, reducing acute kidney injury response, fibrosis, renal recovery or progression. So panel, not a single use of a single type of microRNA, as I have mentioned, combining biomarkers and combining microRNA. New markers such as proencephalins, and these are some of new promising markers. This is, I will leave this, how to design a study according to normal or design patients, one group of normal, and according to high NGAL, these patients with high NGAL, placebo or intervention. This somehow how to design what we need in more studies. In my conclusion, Mr. Chairman, I will come to this recommendation, leaving them as a conclusion. The recommendations of acute kidney injury biomarkers from the Acute Disease Quality Initiative consensus in 2020. ADUKI regarding the use of acute kidney injury biomarker. 23rd Acute Disease Quality Initiative meeting. They recommended that functional care according to new stages of acute kidney injury according to the use of biomarker. These are the functional criteria we are all familiar with. Change of serum creatinine and the change of urine alcohol. They classify according to 1A, biomarker negative, 1B, biomarker positive, 2A, biomarker negative, 2B, biomarker positive, etc. So they classified into this biomarkers according to positive or negative in classification of stages of acute kidney injury. This diagram can show where are we sitting in the case of kidney injury. Biomarker negative, no damage. negative biomarker, no functional exchange, we are intact. No damage, negative biomarker, while still functional exchange, it is only loss of function without damage, which is called pre-renal azotemia. Biomarker positive, while no functional changes, it is still subclinical AKI, early AKI. While positive biomarkers, positive functional changes, it is late or intrinsic established AKI. This diagram can show how we classify AKI according to this. They stated that we suggested that biomarkers of acute damage are not interpretable prior to kidney insult and should not be used for AKI risk assessment. Risk depends on scores I have mentioned. Patient, so use biomarkers in patient at risk for development of acute kidney injury. We recommend in a strong recommendation that validated biomarker to identify patients for whom intervention have been shown to improve outcome. So use biomarkers to make an intervention. We suggest that combining clinical assessment, of course, clinical did not lag behind these, and validated biomarker to triage patient to optimize the timing and type of intervention, the importance of clinical examination, not only the biomarkers. Combination of damage and functional biomarkers along with clinical information be used. So don't use a single biomarker. If you combine one of the damage biomarker and functional biomarker. Functional biomarker is a glomerular and damage biomarker can be tubular biomarker. Combination of biomarker may assist in planning of therapy and management of AKI. Novel biomarker can be used for prediction and duration, suggestion still and duration of AKI. Currently, unfortunately, there is insufficient evidence to recommend the routine use of novel biomarkers to refine acute kidney injury staging. Staging, but not still depending on what we know is regarding serum creatinine and urine output. And thank you very much. Hope that can you get this point? And thank you very much.
Thank you very much, Professor Yasser, for this elegant presentation and very comprehensive, actually, for all kinds of biomarkers in AKI. But your conclusion still, I think, we need more validated trials, actually, just to make it available for routine use for prediction of AKI or for diagnostic or prognostic significant even. I think for the sake of the time, we're going to...
Yes, Professor Kamal, we are still lagging, but I think we have jumped step forwards by classifying, using in classification and using identification and which one to use and which one to use in which situation.
Yes. Yeah.
Go please, and I'll wait for you and listen to the coming lecture.
Sure. I think, as I mentioned, for the sake of the time, we move to next speaker, Dr. Ramy Aboubakr Shahat, he's going to talk about the clinical application of phospholipids A2 receptors antibodies, which one of the famous antibodies that we use in clinical practice. I think, as far as I know, for membranous nephropathy, Dr. Ramy, I think he has a lot of things to talk about in this regard. Please, Dr. Ramy, Faddal.
Professor Kamal and Professor Yasser for this great opportunity to discuss such a great topic, as you mentioned, Dr. Kamal, clinical application of phospholipase A2 receptor antibody. So first of all, I will make sure my slide is moving. Yeah. Clear? Picture clear?
Yes. Go ahead.
So our agenda today is, I will talk at first, give a small introduction about the disease and a few slides about membranous nephropathy. So, and after this, I will proceed about antiphospholipase A2 antibody in the serum and histopathology, and I will finalize by summary and common pitfalls in clinical practice. Allow me just to go through basics for our young nephrologist. I will speak regarding clinical syndrome in glomerulonephritis. We have a common 5 clinical syndromes. First of all, we have a nephrotic syndrome, which is usually present with generalized edema, heavy proteinuria, and hypoalbuminemia. And we have nephrotic syndrome, which usually present with azotemia, active urinary sediment in urine, and hypertension. And we have what is called rapidly progressive glomerulonephritis, which is present with rapid AKI and active urinary sediment, which is called now crescentic GN. And we have also asymptomatic urinary sediment, which usually patient accidentally discover asymptomatically a urinary sediment in his urine during routine investigations. And finally, we have what is called chronic GN, in which patient usually present with advanced kidney disease, and we have evidence of glomerulonephritis, but unfortunately we can't do a kidney biopsy because the patient is now advanced kidney disease. And I want to focus clinical syndrome. It's not a disease. It's just a prescription of clinical presentation, and it's not a specific disease by itself. And we have what is called membranous nephropathy. Membranous nephropathy usually clinically present with nephrotic syndrome, so it's one of the common cause of nephrotic syndrome, and which one of the most common cause of nephrotic syndrome in adult without diabetes. And in some studies, it reached 1/3 of biopsy diagnosis. And we have to just mention again, membranous nephropathy, it's just a prescription, histopathological prescription. We call it membranous nephropathy because we have thickening of basement membrane and we have subepithelial immunoglobulin deposits without no cellular proliferation. And what we have primary membranous and secondary membranous, and as a common cause of secondary membranous, we have lupus, we have malignancies, and we have associated with hepatitis B. So we have primary and secondary. So let's say we have a patient presented to us with nephrotic syndrome. Now it's a clinical presentation. We did a kidney biopsy and showed thickening of basement membrane. This is a histological diagnosis called membranous nephropathy, but still we don't have a clue. Is it a primary related to autoimmune or idiopathic process, or it's a secondary related to malignancies or lupus or medications or hepatitis B. So it was very difficult at first to diagnose. And also we have another dilemma. If this paper published in American Society of Nephrology, which mentioned clearly cancer risk after cyclophosphamide treatment of idiopathic membranous nephropathy. So we can imagine here it's a threefold increase of cancer risk after starting cyclophosphamide in treatment of idiopathic membranous nephropathy. So we have can imagine if we have a patient have a secondary membranous and he was misdiagnosed as a primary membranous and treated by cyclophosphamide, which is already increased the risk of malignancy. And we have another scenario, another primary patient which is treated by medications, increase the risk of malignancy and converted to a secondary membranous related to malignancy. So I used to learn from our professor, primary and secondary is interrelated to each other. So maybe patient started by primary or misdiagnosed as primary and treated by the wrong treatment. There is a change in the treatment or the measurement between. Also, we have to know this information about the prognosis of primary membranous related to the toxicity and the nature of the disease itself. Spontaneous remission occur in 30% in 5 years, and also patient with partial remission spontaneously occur in 30% of patients at first 5 years. And also there is a 30% progress to end stage, but patient who remain non-nephrotic for a long duration, risk of developing end stage during 10 years, it's only 2%. So we have another dilemma here, when to treat, when not to treat, because, you know, again, treatment have a lot of complication, increasing the risk of malignancy. So we have another dilemma, when to start treatment, when to decide, wait and see. Let's speak about our topic today, which is antiphospholipase and antibodies. As we see here, we have what is called glomerular filtration barrier, which is formed of 3 parts. Number 1, capillary endothelium, and basement membrane, and podocyte. Podocyte has a process, in which we have the antigen of phospholipase A2 on its surface. The nature of the disease, one of its etiology and the pathogenesis, we have an antibodies attacking this specific antigens on the surface of the podocytes and causing nephrotic syndrome. This antibodies was discovered in 2009, and it was diagnosed as a marker for idiopathic or primary membranous nephropathy in 2009. And 2011 was diagnosed and confirmed this is a genetic susceptibility of a patient who has HLA-DQ1A to develop such a disease. In 2013, first ELISA screening for autoantibody, and in 2014, a specific epitope for phospholipase A2 was recognized. And we can imagine ECODICO guidelines 2022 now stated that kidney biopsy is not required to confirm the diagnosis of membranous nephropathy in a patient with nephrotic syndrome with just positive antiphospholipase A2 in the serum. So it's a great revolution in such a disease in few years. We just noticed. And I wanted to share with you this systematic review about the diagnostic test accuracy of serum antiphospholipase antibody and the glomerular antiphospholipase antigen for diagnosis of idiopathic or primary membranous. This is a meta-analysis. And you can imagine the sensitivity of the test reaching 80%, and the specificity is around 97%. And the prognostic factor, a patient with high level of this antibodies will most probably will develop progression to end stage, and they will have low incidence of spontaneous remission. And also regarding the treatment, once you started the treatment, you follow the level of antibody in the blood during 6 months, it can give you information about the response. But the problem regarding an antiphospholipase A2 in the serum, the threshold they used to define in the studies, it was not a specific titer, and it was some discrepancy in the results, and there is no specific cutoff which can be diagnosed as a positive or negative. So I will go through the test in separate about the serum and about the histopathology. Regarding serum, there is 2 forms approved by Food and Drug Administration for screening for antiphospholipase. We have what is called cell-based immunofluorescent assay, and we have ELISA. And according to the manufacturer instructions, in direct immunofluorescent stated as a positive signal if the titer is above 1 to 10. And for ELISA, it's considered positive if the titer is more than 20 relative unit per milliliter. And considered borderline if it's from 14 to 20, and below 14, it's considered as negative. But the studies comparing between ELISA and immunofluorescent assay show the sensitivity of immunofluorescent assay is more sensitive. And there is some studies, some center using both of them, they do ELISA and do immunofluorescent assay to compare seropositivity. And we have here a cohort study done on 480 patients, tested both methods for antiphospholipase and comparing by the gold standard, which is the biopsy diagnosed as a primary membranous. And we can see here 110 cases stated as positive by ELISA, and 30 of these cases stated as a positive in immunofluorescent assay. And when this compared with the biopsy, it showed the immunofluorescent positivity is almost 100% with the biopsy. However, there's 80 cases, which is considered as 57% evidence of membranous nephropathy positive in the biopsy, but still negative in the serum. So again, biopsy is still gold standard for diagnosis, and there is some cases which showed a negative antiphospholipase in the serum, but still the diagnosis is antiphospholipase primary membranous. So regarding the biopsy, we have to know a basic information regarding immunofluorescent or immunoperoxidase staining. We have what is called the basic staining, which is include hematoxin and eosin and the periodic acid Schiff and trichrome and silver stain and the Congo red. This is the basic staining. But staining for antiphospholipase, it's not one of the basic staining, and you have to discuss with your pathologist or histopathologist about your suspicious of membranous, because you have to ask to do it, because again, as I mentioned, it's not one of the routine staining, so you have to ask for it. And we can see here in primary membranous, as we mentioned, we have subepithelial deposits, which mainly should be IgG4 to be sure this is primary membranous, or you have to stain against phospholipase A2 receptor antibody of thrombospondin type 1 or serum protease within the biopsy, and it should be granular deposit around the capillary lobe. So it's a pattern should be granular, and the site should be capillary around the capillary lobe only. Because it's regarding secondary etiology, you can see here staining. If you stain the pathology against extocin 1 and or neural cell adhesion molecule or type 3 transforming growth factor beta receptor, this will go for lupus or other causes of secondary membranous. So if you change the type of antigen, you will change the diagnosis. Also, if you have IgA, IgM, and C1, which is called full house pattern, it will go for class 4 lupus nephritis. And if you have IgG change in the type of IgG, like IgG1 or IgG3, it will go more for lupus. And if you have IgG1 and IgG2, it will go more for malignancy associated membranous nephropathy. And if you have also change it from the capillary loop to be stained around the tubular basement membrane, so it will go for lupus nephritis more than primary lupus. So you have to know it should be IgG4, it should be granular stain, it should be around the capillary loop. This is the picture of IgG4 for primary membranous in immunofluorescent. And as we see, it's a granular pattern around the capillary loop, and this is confirmed with primary membranous nephropathy. So we will go to our topic today, which is discussing clinical application of antiphospholipase, and I will start in the diagnosis of primary membranous. Approach to diagnosis of primary membranous, as we mentioned, we have all the patients, this is from KDIGO guidelines in 2022, all the patients should go for all of this as an initial evaluation. And in the last of this table, you can see antiphospholipase antibody titer. And I need here just to focus on a specific point. We have to do all of them. Even if you have a serum antiphospholipase antibody positive in the serum, you still have to do all of them. Because as we mentioned before, still specificity is around 97%, and still we have a patient with serum antiphospholipase positive, and still we have another secondary causes. So still we have to do again all the investigation. As you see this picture, there is intercalating between primary and secondary. So we have to exclude secondary causes. And if we have now antiphospholipase antibody positive, you can ignore a kidney biopsy if the patient have normal GFR and you have no obvious secondary causes or diabetes or atypical presentation. But again, if you still have abnormal GFR, or if you have a suspicious regarding the diagnosis, you can do a kidney biopsy. And this is one of the gray zones which can have some kind of debate between each other, because most of us just find excluding of secondary causes, and you did an antiphospholipase in the serum and it's positive. So you can imagine kidney biopsy, it can be postponed, but there is some studies found that is 14% of the patient which is have abnormal GFR or obvious secondary causes. And when they did a kidney biopsy, they have found another diagnosis which is can interfere with the treatment. Again, you have to go through the whole investigation. If you have a positive antiphospholipase and a normal GFR, and you have no suspicious regarding secondary causes or atypical presentation, so you can avoid kidney biopsy. But if you have any abnormality of this, you still have to do a kidney biopsy. And in the end of this table, you can see still there is what is called antiphospholipase A2 receptor antibody negative, and is still diagnosed as a primary membranous. And there is some tips. It can help you to differentiate if you have such a dilemma. Like as we mentioned before, type of IgG staining. If you have IgG4, it goes most probably for primary membranous, even if you have a negative antiphospholipase in post serum and pathology. And if you have what is called the mass spectroscope analysis, which is a great revolution in the diagnosis, which should change our diagnosis and our prescription about disease. Again, we have another clinical application of these antibodies in risk assessment and the treatment. As we see here, progression of the primary membranous, it depends on three main parameters. Number one, level of antibody in the serum. Number two, proteinuria, and glomerular filtration rate. And according to this three main parameters, we can differentiate our disease to three main categories: low risk and moderate risk and high risk. And this is from last EDICO guidelines. You can see, as you mentioned, there is three or four main categories according to GFR and proteinuria and antibody titer. And the cutoff here used in the EDICO guidelines, it's a 40 relative unit per ml, which is very high, but it's a confirmatory. This is a very nasty disease and it's need to be treated. And treatment now is divided according to this classification, as we mentioned before, according to these three parameters, which is the antiphospholipid, antibody, and proteinuria, and GFR. And if you have a patient with high risk, it's mandatory now to start treatment. You can't wait and see as we used it to do before. And not only this, as we mentioned, after starting treatment, you have to follow the antibody titer. If the antibody titer, which was positive after 6 months of treatment, it's converted to be negative. Now you can start to withdraw our medications. You can taper immunosuppression. You can start to decrease your heavy guns. But if the patient still persistently have antiphospholipase, you can switch to another line of treatment. And if the treatment is not responding, you have to go more aggressive in your management. Not only this, also we have a patient which is developed in the stage and asking you regarding transplantation and the risk of recurrence of the disease. It's also depend on antiphospholipase titer in the serum and the positivity in the biopsy, dividing the patient to three main categories, which is high risk, low risk, and moderate risk, according to the positivity of antiphospholipase in the biopsy and the titer in the serum. So regarding our question, now we have a clue. We have a clue if you have a patient with membranous and you have to diagnose it's a primary or secondary, you have to do antiphospholipase, and don't forget to screen for secondary for all cases. And regarding treatment, you have now our category and our risk assessment to low and moderate and high risk and very high risk. And now you have to classify your patient and to start to treat according to your classification. And I will just go summarize our presentation. Patient with known cancer, without known cancer, and you still have to go age and risk assessment regarding cancer screening for all cases, if not perform it. And the diagnosis of primary membranous, it should not promote extensive search for occult malignancy in the absence of some suggestive findings such as extensive smoking history, positive stool or unexplained anemia or weight loss. Or although some centers go for cystoscopy for all cases where positive microscopic hematuria, which is usually seen in membranous nephropathy. Also, regarding the positive test for antiphospholipase, it's less likely to be a cancer-associated membranous, but we have to go screening and only requiring screening for the same frequency as general population. And regarding antiphospholipase antibody test is negative, and you have no other explanation for this disease except it's a primary membranous, not a secondary. You have to go through and you have to investigate frequently for malignancy, especially if your patient is not responding to treatment. You have to revise yourself, and there is one study showed that biopsy-proven primary membranous and there is increased risk of malignancy around 10-fold. So screening is still very important, and positive test for antiphospholipase doesn't totally replace kidney biopsy, especially if you have abnormal GFR, clear secondary cause, diabetic patient, or those with atypical clinical presentation. And I will finalize my presentation with this picture. We all need money, but we should not forget learning is a treasure that will follow its owner everywhere. And thank you.
Thank you very much, Dr. Ramy, for this very comprehensive talk about antiphospholipase receptor inhibitors, antibodies. And you really showed very clearly the value of assessment of membranous glomerulonephropathy by anti-B-little-R antibodies. And I think now it's time just to welcome again by our attendees. And we have with us Professor Faisal Shaheen, Professor Hisham Sayed, Professor
Shaheen and Professor Hisham Sayed. And we have a question from Muhammad Abdelhamid. Very, very ridiculous question.
Yeah. And
how can you screen for malignancy? In fact?
Thank you very much again. I think it's time now just to open the question to the floor. I think it's like what's been known for the Zoom meeting. If you have any question, either to raise your hand or to write down your questions on the chat, and Professor Yasser will just convert to direct to the speakers.
Dr. Muhammad Abdelhamid says, how do you screen for malignancy? This is a very big issue. Which malignancy?
How each specific age group, so male or female, or according to
this is the important.
Specific. I mean, I have a patient with membranous nephropathy, old age, male or female, and I'm searching for a hidden malignancy. There is no, the patient is negative anti-PLAR. There is no clear evidence of malignancy. I mean, there is no weight loss or what. I have to exclude malignancy in these cases as a secondary cause or not, and if yes, and there is no target organ I am thinking of as a cause of malignancy, how I have to screen in these cases for malignancy.
If you allow me, Dr. Gawad, please, negative antiphospholipase A2 receptor antibodies does not signify only secondary, but it may also signify malignancy and the malignancy-related glomerulonephropathy. Which one? But negative antiphospholipid antibodies, it's one of the issues that you may think about malignancy. And at that time, you look for the clinical criteria, which may be the clue for your diagnosis.
And excuse me to add, Professor Kamal, to your answer, that screening for malignancy, there is some guidelines known to screen for which malignancy in males and females and at what ages. For example, cancer breast, for cancer colon, cancer prostate. These are common malignancies, are common in certain ages and in certain clinical situations. If you don't have a localizing symptom or a localizing sign, focusing to a single malignancy, I think we are to follow the guidelines for screening regarding males, females, regarding age, regarding family history, regarding the persistence of other conditions.
I think malignancy-related glomerulopathy is one of the very big issues actually, and is not only covered by antiphospholipid A2 inhibitors, antibodies, but I think it needs more and more sophisticated and specific tests to to exclude or to confirm malignancy.
Professor Hisham Said wants to comment.
What criteria would allow you to do so?
Thank you very much. I really enjoyed. I may miss some slides, but thank you very much, Professor Dr. Yasser, very comprehensive. And as well, Dr. Ramy, a new star in the Zoom meeting. All are driving by a pioneer in nephrology, Professor Kamal Aukasha. So today is a bouquet of pioneers in the field.
Come in this meeting, actually, you reach all Zoom meeting, Professor Hisham, as usual.
Thank you very much. I may miss some slides, but I have 3 comments. One comment is coming from the end. Which malignancy and which of symptoms of malignancy hidden before the development of membranes? Actually, it's written in the book, but usually it didn't find in the clinical. And it is very difficult to diagnose hidden malignancy because usually malignancy develop with symptoms prior to renal involvement. My second comment to the, Professor Yasser is procalcitonin. We have in our study that once the patient started high volume convection therapy for acute kidney injury, procalcitonin is dialysable. So it is removed by dialysis. So I think the biomarkers, all of the biomarkers are mainly for academic studies like NIGAL, interleukin 18 and else. But I wish that we can follow the patient by interleukin 6, for example, for the sepsis, acute kidney injury, or other biomarker except procalcitonin.
Professor Hisham, excuse me to comment for this. We are speaking about these markers are designated to early detection. We are searching for a marker for early detection. So removal by dialysis, I think it's very late and not our concern.
Yes, if you have, sure. If you have a patient with acute kidney injury and the progress, and we can see that in the ICU, procalcitonin is tested on a daily basis, and patient on CRRT, for example, or for slit techniques or with high flux dialysis membrane. So we always say to ICU people, don't test for procalcitonin anymore because it's dialysable.
For me, one marker is except that troponin, what succeeded to do in cardiology, we did not find much more markers to do like this. All markers are in combination with clinical picture, and the main validation is for follow-up. Taking a base reading and later on follow up the clinical condition in addition to the clinical condition improvement or progression or etc. But searching for a marker that resembles troponin, even late in acute kidney injury, such as procalcitonin or something that you are talking about, or early, such as in GAL or TIMP2 or IGF-P2, still lacking behind the use of single markers resembling.
We have to pay for the clinical presentation, urine output as well. Biomarkers for sure is one of the predictors and the prognostic, but sometimes there is the free-handed in the ICU are calling for everyday testing, and it's of no significant value. Just to highlight that for all the audience, especially the juniors.
Biomarker of acute kidney injury everyday testing?
Yes, they are testing
We are
renal profile,
to
procalcitonin.
divide now, searching for acute, early diagnosis of acute kidney injury, or you are speaking about procalcitonin in late stages. I am speaking about this. Procalcitonin used as a pro-inflammatory marker.
I understand you don't miss this point, Professor. You don't miss this point. Just to highlight for the junior on the serial.
Yes. Okay.
Biomarkers of pre-development or early development of acute kidney injury and progress to acute kidney injury necessitating renal replacement therapy. So I understand the talk well, and you handle excellently, describe all the biomarkers for early detection of acute kidney injury. But just for an information to the juniors that if you have a patient on renal replacement therapy, don't depend on the prognosis of procalcitonin. That's of our clinical parameter. My last comment to Professor Ramy, I have a case scenario, and you can advise, is it rationalize it or not? I have 3 or 4 years ago, very VIP person, and was treating for diabetic kidney disease, diabetic nephropathy with 7 grams per day proteinuria in Germany. And occasionally, they asked a second opinion, min al-abdillah. So I was worried about that. This patient is very VIP and treating in best hand centers in Germany, and asking me just to have a look on the treatment. And I remember that they are giving him sodium glucose transporters very early and so and so, and huge doses of ARBs. But interestingly, I tested the patient for antiplar, and it was positive.
Yeah.
And I did biopsy. It was membranous.
Dr. Hisham, you are eminent figure in nephrology. And
thank you very much.
Yeah.
Thank you very much. So it was positive antiplar, and the patient did a biopsy, and it is membranous, and he took at that time Indoxan bi-monthly doses of 500 milligrams and completely recovered. So I understand that some of patients with diabetes may be presented by another. So what you can suggest is that if the patients and simply the patient with diabetic kidney disease and the heavy proteinuria, and you think that the progression and heavy proteinuria is not aligned with the history of the diabetes and the progress of the diabetes, and so, do you think that we can incorporate antiplar in some patients with diabetic, even for screening?
To my knowledge, I think it's not being configured as one of the biomarkers. There are lots of biomarkers for management for the diagnosis of or early detection of diabetic nephropathy. But as far as I know, antiplar is not one of them.
Yes, but if you have a history, short history of heavy proteinuria in a diabetic patient, you may suggest that additional pathology is present. I am not seeking to do antiplar for all patients with diabetic kidney disease.
Just on individual basis. Yeah, Dr. Yasser.
Excuse me, Professor. I think
I have Yasser Abdelhamid.
Yes, most welcome, Professor Kamal. But I just want to add one point to Professor Hisham. What Professor Hisham said in this point, I think we can apply the usual what we know in suspicion of this patient is not a diabetic nephropathy. This can be a very good idea, and if we are suspecting this patient to be not simply a diabetic nephropathy, can be something else, we can apply this as a known criteria to test for or screen for antipar A2 in serum.
And it's easier than biopsy.
Yes, I think this, but of course, this, if we suspect this membranous is the first diagnosis, we can find another one, but this can be a good idea to screen for.
Sure, if you have a heavy proteinuria, no tension, no active sediments,
yes,
renal profile is within normal, no hematuria.
Especially in cases of rapid progression.
Yes, just to highlight that.
Welcome,
thank you very much.
Welcome, Professor Al Kamal. I'm ready.
Dr. Yasser, I was wondering about the role, maybe just one of the biomarkers, fibroblast growth factor 23. Do you I was referring just discussing one of the theses in Mansoura MD thesis in Mansoura University Hospital very recently about the fibroblast growth factor as one of the biomarkers for acute kidney injury. Surprisingly, it was very useful actually in diagnosis and moreover in the prognosis of the acute kidney injury in terms of progression. It's for outcome basically in the stage kidney disease and the declining of the kidney function and predicting chronic kidney disease.
Of course, these markers are all of these markers, and till the point we have found conclusive markers, search will continue about other markers that may be more useful than the commonly found markers. If you look to this classification of markers, I think you cannot found the place of fibroblast growth factor here. So it may be an interesting point for search, maybe an interesting coming biomarker for acute kidney injury. Who knows? Maybe.
I was surprised actually.
I found that is really, and I want to know the background of searching for this marker in acute kidney injury.
If you don't mind, just I can send you my the thesis, the synopsis about the thesis actually just to read it. And
it's very interesting that to find
very
that.
Interesting.
Under supervision.
And I want really to know the background of this.
Abdelhamid and Dr. Muhammad Kamal Nassar, he's one of the authors actually, and just I thank them very much actually for inviting me to defend this thesis. He's one of our young researchers, his MD1, and I just got astonished by the result. Was very interesting. So again, I think we come to the end now, Dr. Yasser, or
we have still Professor Faisal Shaheen wants to comment, and we have a question from Gawad. Another question from Gawad.
Yes.
Say, what is the availability of markers of membranous rather than anti-PAR A2 and THSD in other countries?
If you allow me, Dr. Yasser, I have just a comment regarding first question of Dr. Gawad. I also we have a case which is presented to us again with a nephrotic syndrome, and we did a kidney biopsy and the serology for antiphospholipase, and it was negative. And we did the screening for malignancy, and finally we just have a small cyst in left kidney, which we consult two big names of urologists about this, and it showed no malignancy, no signs of malignancy. And we started treatment of this patient as a primary membranous, but unfortunately this patient showed no response. After 6 months of treating with cyclophosphamide, a patient has a persistent nephrotic syndrome, not responding to treatment. So we revised ourselves, and we again consulted another urologist regarding this cyst, and we finally decided to do a partial nephrectomy for this case. And you can imagine the pathology came renal cell carcinoma, and the patient responded very well after the surgery. So again, we don't know if the patient started as a primary and after cyclophosphamide it became secondary, or it's a secondary from the start. It's a dilemma, but we have to revise ourselves, especially in such a case is not responding to treatment. This is regarding Gawad first question. Also regarding second question, thrombospondine, some very few centers outside Egypt using both serum and staining of and histopathology for thrombospondine for diagnosis. But other marker, I don't know if there is another. In Oman, we have some cases staining in thrombospondine, but it's not a routine case, not a routine staining. Just a few cases, and it was all negative. So we have no great experience in using and diagnosis of primary or second membranous again, but I am the other candidates.
Okay, Professor Faisal Shaheen, please.
Okay, thank you very much. I enjoyed the two talks, and I think this is the future of nephrology. But my statement probably it come after you, Yasser, you maybe conclude some important issue that we should go with whatever we have it as a diagnostic value at the moment, because it is for sure we can diagnose any case of acute kidney injury by serum creatinine and urine output, and we can manage according to this. Still, we don't have good biomarker which show to us exactly how things going, like a BNP in cardiology. We don't have it till now. We probably, as you said, that we could have some new markers coming, which will show to us exactly where we are in diagnostic value. And again, the dilemma of PLA is still there. We still membranous, we diagnose it clearly by biopsy. Even was Kidiko when they recommend lately that we should, there's no need of biopsy. I think we still need it for a long time till things become more established. Thank you very much.
Thank you, Professor Faisal. And these biomarkers is still not for risk assessment. This is what I really want to stress about. Still now, not for diagnosis. Diagnosis of AKI, it may be led done by urine output and the criteria for KDIGO, or we know. But it is for risk assessment first before the use of biomarker. Risk assessment depends mainly according to risk scores and many risk scores I have mentioned. So as this patient, no AKI, suppose that all patients with no AKI, which will go to AKI and which will not go to AKI according to risk assessment. The next step till now is the use of biomarkers for this stratification of these patients with high risk according to scores. Of course, as you said, no marker till now to stay in the first, diagnosing which patient with acute kidney injury, but it is still after assessment of the risk in patient not having acute kidney injury. And I have a comment for your second comment that not do a biopsy for patient with positive anti-blood. I don't think no one of us will give this heavy strong immunosuppression without having a biopsy. I think biopsy tells more than simple diagnosis. Fibrosis, degree of sclerosis, association of, for example, interstitial nephritis with the primary lesion, glomerular lesion, many, and you may can find some surprises in your biopsy that can be guiding to some diagnoses, such as having surprises for multiple myelomas or casts. For some biopsies, we did not expect the patient to have something like this. So I don't think, for me, this is a personal, apart from KDIGO recommendations, that one of us will go to treat with heavy immunosuppression without having simply a renal biopsy, looking for the kidney as a whole, not for the initial diagnosis.
Agree with you 100%.
Thank you. Ahmad Mabruk Sheikh.
I have one comment, Dr. Faisal, please. Yeah. According to the data that you have said in terms of patient with positive anti-PLA2R is not in need, according to KDIGO. Yeah, I'm just usually I've confronted with patient with nephrotic syndrome as adult nephrotic syndrome with the full-blown picture of nephrotic syndrome. So do I have to ask for anti-PLA2R for every patient with nephrotic syndrome? According to that, or to go according to the criteria that we all know that adult nephrotic syndrome is candidate for renal biopsy from the start?
Well, I think Hisham mentioned that if we have someone with no active sediment and no proteinuria, I think we should go for that. Otherwise, no need. I think Hisham mentioned this clearly, which I agree with him. If someone had proteinuria with no active sediment is different from someone who already have active sediment, and we should biopsy to know where we are exactly.
So you say that the patient with active sediment is the only one who's candidate for renal biopsy?
No, any proteinuria, hematuria, anyone can go for that. But I speak about someone about membranous especially.
Proteinuria is indication for renal biopsy. Is that right?
Sorry, again, Professor Kamal?
Adult nephrotic syndrome with nephrotic range proteinuria. Isn't the indication for renal biopsy?
He is for
Yes.
renal biopsy.
Yes, I think.
Yeah.
Of course, this is what I said. No one can.
You can have amyloidosis, you can have multiple myeloma, you can have malignancy, you can have many other things.
Let me ask you in return, Professor.
Yeah, to widen the spectrum, not just to focus mainly on the, as if the all nephrotic syndrome is only membranous. So
Yes.
I think I'm asking for me or all of us, asking for the serology for whatever. And if you ask me, do you ask for anti-double strand ANA for any patient with bland nephrotic syndrome, bland sediment? Do I ask for example, anti-double strand? I ask for ANCA, I ask for C3 or C4 for any patient with adult nephrotic syndrome with bland sediment?
Yes, let me ask this in return, Professor, this question. How many times did you find a surprise in the biopsy apart from your clinical findings? How many times did you diagnose this patient clinically as having a certain disease and found something totally different for the clinical diagnosis? I think many times. We found how many patients with lupus diagnosed for the first time with renal biopsy?
I urge for the role of renal biopsy, and don't forget the dogmas that we know that renal biopsy is an indication for all adult nephrotic syndrome and nephritic of course.
Of course, any abnormality. I think KDIGO classification, my feeling is that this was for a patient, for one who is knowing this patient is membranous. He is already knowing the patient is membranous, not diagnosed. The last one for the last question from Dr. Ahmed Mabruk al-Sheikh. You can ask to Professor Kamal directly. Why asking on the chat? We are seeing you sitting beside him, asking to his friend Ramy in the treatment of primary membranous with flour positive. Does Induxan have the result in positive flour? Have the result as rituximab?
دكتور ياسر هو يعني بروفيسور كمال عكاشة جنبه يعني فهو يعني اذا وجدت
Let me skip this point. Let me skip this point and answer him.
Clearly for guidelines still tell cyclophosphamide is a heavy gun. Still superiority in the cyclophosphamide, although most of the studies showing rituximab is not inferior in the treatment to cyclophosphamide. But we all know cyclophosphamide is a heavy gun with much side effect, but more effective. This is my opinion also. I'm looking forward to hear Dr. Kamal's opinion.
No, I'm not favoring actually prescribing Induxan in patients with membranous nephropathy from the very far beginning. As we all know, membranous is maybe the role of third. One may respond spontaneously without treatment, and the patient may respond to steroid, and the third is non-responder. That's what I am following actually. Okay, either after following this criteria, either to go for Pontocelli or to go for rituximab, for example, is one of the the issues now. Okay, so I think I don't favor actually prescribing Induxan initially for patient with membranous nephropathy.
I agree, but he just asking regarding which more superior in treatment, which is more aggressive or effective in treatment. I think, as you mentioned, Dr. Kamal, we hate cyclophosphamide, but still, in some cases, we still need it.
Yeah, which one? Which one? After failure of the other measures, of course.
Yeah, after failure, yes.
Yeah.
Dr. Ahmed Gila shared us some a nice diagram for treatment of membranous. Please have a look for it. And we have no more questions. Thank you, Dr. Ahmed. We have no more questions on the chat and no more comment. Professor Kamal, and close.
Thank you
Close now.
Yasser and Dr. Ramy for this elegant presentation and very fruitful night, actually. Thank you very much for joining us, Dr. Faisal, Dr. Hisham Said, Dr. Hayam Al-Aggan, Dr. Muhammad Gawad, and everybody shared us tonight, and looking forward to see you more and more, Dr. Yasser, Dr. Ramy, and all the team of the ASNT Zoom meeting. Thank you very much, and have a good night.
Thank you. Thank you very much. I will close now. Thank you, Professor Kamal. Thank you,
Thank
Ramy,
you
for coordinating this and for your talk and for doing this job. And this is the time to close and announce for the coming meeting, which will be next Wednesday, inshallah, 9 p.m. Cairo time, waiting for you all. Will be by Professor Samir Kamali speaking about cardiovascular management, especially acute cardiovascular management in chronic kidney disease. Waiting for you. وتصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام. Good night.